yeah, I'm Erik Shipley, psychiatrist and child and adolescent psychiatrist. Did my fellowship at UH, and now I'm in yeah, kind of like private group practice, I guess. But yeah, happy to be here. Always love teaching, and hopefully this can be kind of a little bit. We'll kind of get through some of the information, but then I'd love to save some time to for people to just kind of and maybe even like bring up a case or two, and I can just kind of we can do some like I don't know like rapid fire here. This would be my intuition, and this is where I would like to go, where I would typically go first, um, before maybe getting to some of the bigger guns that a psychiatrist might use. So here we go. Um, so I think we should all know, what are the actual FDA approved SSRIs for kids. What we basically find out there is that there's not much, and it's just the wild, wild west, and everything's off label. Um, Almost. Okay. Um, Identify sleep problems and clinical relevance, circadian rhythm disruption, and then some basics of apnea metrics as seen through the eyes of a psychiatrist, which is going to be interpreting these numbers differently because of the different energy demands of the brain um, and the nervous system in general. A little discussion about concussion and subconcussion, the difference and the clinical relevance, um, long COVID symptoms and how it affects the brain and some common behavioral changes that we see, along with other post-viral infectious or autoimmune problems. Enhance patient outcomes through early intervention. You guys are at the front lines. Um, Most SSRIs are prescribed by primary care doctors, not psychiatrists. That just is a volume difference there. So, helping you guys out with some other interventions that can hopefully kind of not only get the ball rolling, but frankly, some of these interventions that you guys can do that aren't medication related or standard antidepressants related. They're really powerful, especially over time. So just thinking about it now, probably, I should have put a slide in here about not just time management, but I guess like scheduling management. Um, Psychiatrists have this luxury of seeing patients sometimes once a week. Not to say that you guys need to do that, but sometimes it can be helpful to ramp up those appointments when you're doing a couple of these types of interventions that I'm bringing up that are like seemingly small, but kind of like a high interest savings account or a good mutual fund. If you keep putting money in it, it doesn't seem like a lot each time, but over time, it really adds up. And in 20 years, you can either be retired or not, right? Um, so kind of thinking about it that way. Am I gonna, okay, so people are admitting, I just see the admission, somebody else is admitting uh, in the waiting room
Yes,
because
we'll
it comes up.
close the
Cool,
editing
cool.
and
Okay.
monitoring the chat.
All right. So yeah. So we got SSRIs. Um, and for kids, the main ones are really Prozac, Zoloft, Lexapro, and then Luvox. Luvox is really reserved for OCD. Doesn't seem to be too helpful for anxiety and even less helpful for depression. Sometimes it's helpful for anxiety if the OCD is really anxiety provoking or leads to anxious behaviors and avoidance that then builds up into a full-blown anxiety disorder. But usually for the way that I was taught in fellowship is you think about Lexapro kind of covers anxiety and depression. Prozac covers a bit more depression, and Zoloft a bit more anxiety. Um, But then, patient differences, it ends up being six in one, half dozen in the other. You kind of get started with one and you track response. Um, but technically, there are the FDA approved medications for pediatric population. Um, but we do end up utilizing other medications, citalopram or Celexa, Wellbutrin, Remeron. Technically, they're off-label for kids, but can be effective in certain situations. Um, that's on the SSRI front. Um, our clinic has been treating treatment-resistant depression for a long time, um, and it's taught us a lot. And there's more and more conversation, right? I think in a lot of fields. What does treatment resistant really mean? Is that the best terminology for the entity? Or could it also mean that it's just not, we haven't been using the right treatment for the entity we're treating? And therefore, it's not really treatment resistant. We haven't found it yet. Kind of like our lovely term idiopathic. Um, maybe it means that we just don't know what it is yet, right? We haven't fully defined that thing. So, kind of similar what we learned while we're treating treatment-resistant depression, um, with the standard modalities, medications, and eventually a lot of times we'll use transcranial magnetic stimulation, is that some patients got better faster. Some patients didn't get better at all. And then what became even more interesting is the patients who got better, some of them stayed better, and some of them got bad again, and got sick again. So what we have been working on for a number of years now is to identify, especially identify how do we help patients to have enduring outcomes? How do we help them to not have to see us as much? And these are some of the factors that we've identified. I'm sure there are more out there. Looking forward to seeing what they are, but here's the big ones that I think are also really relevant to you guys as pediatricians. So kind of grouped up as sleep, which has sleep disordered breathing. We'll kind of talk a little bit more about what that encompasses. Um, Nasal breathing problems and concussions and long COVID. Um, So long COVID, of course, is more relevant now than ever before. But I think that's we can actually expand that to other entities. People have probably heard about PANS, pandas, kind of a similar idea here where person gets an infection and the body learns to attack it and unfortunately learns to attack itself too. And so the level of discernment that the immune system has in that individual is somehow compromised. And then we get these post-infectious autoimmune problems that can really affect the brain, particularly in kids, although I've seen it in adults too. Um, so let's see here. So on the circadian rhythm disruption part, man, I have just been blown away this year by how powerful that thing in the sky is, that sun thing. And I have to remind myself, it's actually almost made me a little bit spiritual. Um, like there's a reason why polytheistic religions have usually the sun god is the number one god. In Christianity, what did God do on day one? Let there be light. This really powerful thing up there in the sky that that runs off of, it introduces this whole concept of light and how does it affect the body. The circadian disruption that's happening for kids these days, and for adults, right? But kids are particularly profoundly affected by this, even more than adults, it seems, because their brains aren't as developed and they're not as myelinated. Um, and and they haven't really fallen into a consistent routine in life, and their bodies are still changing, right? And so when we disrupt that anchor point with the sun, there can be some it seems like some profound downstream effects. And so one of the things that we're always looking to screen for is circadian disruption um, at every assessment. Um, a lot, as you guys are probably more familiar than us, a lot of parents, they don't even know that, you know, a 5-year-old needs more sleep than an 18-year-old, and identifying that can be a huge step towards um, rectifying a lot of psychiatric problems. Um, so there's a bunch of words on here, but turns out there's, clock genes involved, melatonin secretion, neurotransmitter systems and hormone systems are tied to circadian rhythm disruption. And you can kind of quickly see how if there's circadian rhythm disruption, there's just this chronic assault of the autonomic nervous system. So how do you make a kid anxious? Turn their sleep upside down, put a bright light in front of them at 11 p.m. and try to get them to wake up on time for school. Gonna end up with a cranky, disruptive, defiant kid. Um, so so that's a big one, circadian rhythm disruption. And Yeah, some of the challenge with it is that I always try to come from a place of compassion for parents because, you know, the parents that don't care, they're not even bringing their kids to us anyway. So, if they're coming in, it's like, oh man, my heart goes out to them because I'll tell parents, man, and I think it's real. I don't think it's ever been harder to be a parent than 2025. And it will be harder in 2026, and it'll be even harder in 2028. It's just getting harder because society is not changing in a way that there is there's just a constant pull for families to not be able to live healthy. Or another thing that I've thought about recently is like, it's never been easier to survive, right? Um, but it's also never been harder to be healthy, and therein lies kind of the crux of a lot of what we deal with, which is unfortunately, and what burns us out is the chronic disease part, you know. Um, you guys more so than us psychiatrists are specialists with acute disease. And it's so satisfying, someone comes in with a big problem and you can fix it, awesome. But mental health is a chronic disease problem. And so that's why things like this, chronic variables that are chronically affecting an individual, but at a low grade level, is where the money's at when you really want to help somebody in the long run. Um, so circadian rhythm disruption, here's a chronic issue to screen for. So sleep apnea and sleep disruption, um, it seems to be more and more prevalent. And It's just so much to talk about here, but the basics is be, I think we come out of medical school with a bias that obese people or overweight people are the only people that can have apnea. Um, and full-blown apnea where your breathing stops, maybe there's something to be said there. But man, we've been getting sleep studies for most of our patients for years now, and I was just always blown away by how many really skinny kids have sleep apnea. Um, and and it seems like there's it seems like the cranial bone, the skeletal part of the airway, not the soft tissue part that obesity affects, but the skeletal part of the airway is getting smaller. And you know, there's probably not enough time in a whole week even to wonder and ponder why, but that seems to be the case when you look at studies of skulls from back before the modern industrial age compared to now. I think it's like the Aborigine population in Australia, after 2 generations of exposure to modern living, their sinus and nasal airway volume has decreased something profound, like 50%. But even if it's 10%. That's actually pretty substantial considering, again, it's a variable that's affecting a person with every breath, right? So seemingly benign problems from a number standpoint, especially with what we're used to seeing in like the hospital where everything is on full blast, um, it's a problem over time for somebody, um, and can lead to a chronic disease issue like anxiety and depression. So, so when you're looking at these sleep studies, keep in mind that the person who invented the AHI, apparently he, like on his deathbed, a little bit of hyperbole here, but um, was really regretful of creating that metric because he felt like it wasn't really it was um it was specific, but it wasn't very sensitive. And there's a lot of people with breathing problems that lead to sleep problems and brain recovery problems, and therefore neuropsychiatric problems, leaving a lot of people out. And so we were underdiagnosing with the AHI. So there is a thing called the RDI, that is the respiratory distress index that does seem to encompass more breathing problems that can lead to brain problems. And I think the biggest thing that I want to share with you guys here is when it comes to sleep is the REM sleep is really, really important when it comes to helping somebody with neuropsychiatric problems. REM sleep is when we have emotion memory decoupling. And if any of you know how trauma therapy works, exposure therapy for trauma, for example, um, good old CBT, what we do in a CBT session for trauma is we help somebody to talk about what happened without getting pulled in and stuck in the emotion or of how it made them feel. Okay, so that's the very basics of trauma therapy. Um, Basics as in like that's the goal. That's the backbone. That's actually what's supposed to happen in REM sleep. So for two, if you're supposed to have like 25% REM sleep a night, kids sleep in, let's say, 10 hours, you're supposed to have like a 2.5 hour trauma therapy session every night. And it turns out that REM sleep the quality of it is highly connected to how well someone is breathing through their nose. So if you have a kid who is open mouth breathing throughout the night, you know that they're not getting the kind of REM sleep that they need. And they will have energy issues the next day. Yes, a lot of them will have fatigue, but a lot of them will also have a lot of irritability. And those are going to be the kids that parents feel like they can't put boundaries up with or have expectations for because everything triggers them. It's the people that, in anyone's life, but for our patients, that like people are always feeling that they're walking on eggshells around. Those are very most likely going to be having a REM sleep problem and a nasal breathing issue. So, so there's more to this than just the standard apnea that we think about and helping somebody, with their headaches and their heart issues. When it comes to kids, um, I think the reason why we end up picking up more on it in the child psychiatry world than maybe the child cardiology world is because sleep apnea, it affects the organs the soonest, the organs that need the most oxygen. And the nervous system is almost 100% oxygen dependent. And the most oxygen utilizing part of the brain is the front part of the brain. And so I guess I should show a little thing here. Am I doing screen share or let's see, I'll do screen share. So I show this to patients a lot and parents. Cranial nerve 1 has a lot more functions than just sensing smell. There are great studies now. There's one in Nature showing that respiratory oscillations, or sorry, respiratory rhythms are phase locked to brain oscillations, particularly in the front part of the brain. Super fascinating research. But basically, what this means is that the nose acts as a governor, like on certain automobiles when they don't want it to go up a certain speed, but it could. It acts as a governor for how fast and how much energy the front brain is using. Um, so, so this relationship is kind of at the crux for so many of our patients. And so when we ask patients, um, or parents of patients to begin to do simple little things like treating allergies, it can go a really long way. Not because the person feels better because they aren't as reactive to dust, for example, but because we reduce that congestion in the nose, cranial nerve 1 gets more stimulation, and the front brain is allowed to turn on and begin to utilize that oxygen better. And so then those functions of the frontal and prefrontal cortex can start to activate, and they can begin to do neurological functions, neuropsychiatric functions like letting go of something, right? Oh, my kid just can't let go. Or pivot when there's a change in the schedule. Or begin to take to see where the parents are coming from. These are common complaints that parents have, but they're more difficult um, kids. Um, so the sleep apnea, yeah, it's less about apnea and more about nasal breathing disruption that I want to share with you guys. So, quick tip there. Um, somewhere. So this is some of those. So we like to collect data, and maybe another time, if you guys want, I can tell you about how to interpret spectral EEGs. But this is a distribution of brain waves, so not a continuous EEG. Can't tell if somebody has a seizure based on this kind of EEG, but the same data compiled and presented differently. And so this is three separate spectral EEGs, and the dates are there at the top. And in this series, what we see is on March 6th, we don't see um, peaks in the middle here. So this middle region represents alpha activity. And the way this is collected is somebody has their eyes closed for about 4 minutes, and they're asked to just think of a white wall. You just give them one thing to try to sustain their attention on. Doesn't really matter what it is. And then you see what kind of brain waves come up. So on the left here, we notice that there aren't too many peaks here in the middle, just in the back of the brain. This is near the visual cortex. And we got a little bit here, C3, FZ, F3. So what we did for this kiddo is said, hey, you know, let's start off. The parents, I just said, let's start off with, because he was really stuffy and congested, and he was kind of a obvious case there, but said, hey, let's start. I think the pediatrician had already picked up on allergies, wonderful. And they started, I think, Montelukast, cast. And I said, hey, let's beef it up. Let's throw some cetirizine in there, Flonase twice a day. Not just once, but twice a day, because we want good nasal breathing all day, not just during sleep. And at night, start using breathe right strips, those little nose strips that are kind of stiff, right? Open up the nasal cartilage on the outside. Um, so then we met 4 weeks later, April 3rd, and voila, start to see a little bit more activity on the left here, consolidated peaks, shows more rhythmic activity. And then in the middle, boom, we got taller peaks here. Wonderful. So I said, how's it going? What do and this is, mind you, a month later, this is our second meeting. And we got this brain map, and I said, hey, it looks like things are kind of progressing, but I'd like to see it progress a little bit further. How are some of the symptoms? This kid started off suicidal. Okay. And that's just to show you how powerful seemingly benign interventions are over time. Okay. So he's suicidal. He'd meet criteria for ADHD. He would meet criteria for anxiety. He would meet criteria for depression. He's one of these like pan criteria kiddos. And so, but we started here. Obviously we came up with a safety plan and all that stuff. And, parents could call anytime. And I made sure that the parents, are capable of holding the kid, accountable and that they were going to be present. So, so I said, all right, let's go. Let's try this out. And sure enough, he is starting to have more energy, a little easier to get going in the morning, and but still having some trouble going to school. I said, okay, well, so let's make sure, you guys are doing it all. And it turns out that he was actually only using the nose strips, like every 4 days or so. Not every four, like 3 to 4 days a week. I said, okay, well, let's step it up to 7 days a week. All right. And I guess it was falling off the nose. And so he just kind of like gave up on it a little bit. So I said, okay, use soap and water, make sure, get it really dry. Parents, like, let's do this all together. A lot of times that can be really helpful too, because these interventions are easy for everyone in the family to do. So you get the whole family to do it together. And then you get these like knock-on bonuses where the parents are a little more, energetic, less burnt out, and more relaxed, which is also good for the kids, right? So so we amped it up to every day, and then 2 months later, had them come back, and we have way more peaks in the middle. And all of the symptoms started to get even more better over time. So I just want to show you that, guys, that just to show, okay, how powerful are these seemingly benign interventions if you do them over time. Um, so let's see. When it comes to sleep, it's having late bedtimes ends up being a strong predictor of depressive symptoms. So, just to arm you guys with a little bit of, you know, literature that you can share with parents and give them a little bit more confidence and motivation to take that darn phone away. Um, The social jet lag part, I think, is really key. It's this little nuance that isn't talked about enough. And there's a quick way to deal with it. Um, Weekend Warriors is the adult version. But when kids and families, frankly, stay up later on Friday and Saturday, that ends up with a twofold increase in mood symptoms. So we call it social jet lag. And one way that I like to deal with it is, it is, I think there's a certain like spice of life effect to stay up a little later, but maybe one night and only for 1 to 2 hours, and pick that. And ideally, it would be Friday so that Saturday night and Sunday night, you can get back on track. And Monday morning won't be the eighth ring of hell. Um, and so, so that's usually how I work with that. So pick one night, Friday or Saturday, ideally Friday, and no more than 2 hours of delaying that normal weeknight bedtime. Um, and that usually does the trick because I don't know, families got to be bad together sometimes, maybe not more than 2 hours. Um, all right. How's my time, guys? Let me see. 105. All right.
Yeah, we still have plenty of time.
Got it. Okay, so concussion and subconcussion. Key takeaways here is that you do not have to lose consciousness for your brain to incur a problem after a head impact. Um, Even just feeling a little bit stunned can do it. Um, Now, if you have had a head injury that results in dizziness and increased hearing sensitivity and visual sensitivity, and brain fog, those are, you know, those should be treated sooner than later. And so, unfortunately, um, the concussion s- treatment process, it hasn't included what we've found to be the most remarkable. I would say two of the most remarkable treatments for it, which would be transcranial magnetic stimulation and something called nasal release technique, which is borrows from the chiropractic tradition and the osteopathic tradition. But basically, when a head injury happens, um, the ER docs are doing the right thing. We got to make sure we rule out the worst case scenario, which would be a bleed, because that needs to be addressed immediately. But then a lot of patients will leave without much care after that. Um, and and I don't think that's really a fault of any provider. I think it's just the system that we work with is it hasn't caught up yet with what we can do for these patients. And those two treatments that I just mentioned though are more off-label, and so then you get into an insurance payer issue and things get more complicated. So I get why the issue's there, but I want to share with you guys some of the observations that we've had in our clinic that have been rather remarkable. Um, with transcranial magnetic stimulation, there's a way to use it. So consider this magnetic field generator that goes on someone's head. That's transcranial magnetic stimulation. Consider that as a scalpel. Depending on what kind of surgeon is using the scalpel and how they're using it, you get different effects. And the same thing holds true with a magnetic field. So there's a way to use it in order to really quickly help with someone's concussion. Um, Similarly, the other thing that can help is going to be the craniofacial release or nasal release technique, which is basically using a small balloon that goes in the nose and puts back the cranial bones that moved in response to the head impact. Um, and that ties back into what I shared with you guys earlier about the profound effects on the brain that happen when you increase stimulation of cranial nerve 1, particularly in the prefrontal and frontal cortexes. So, brain fog is a common symptom after concussion. And so you have this concussion, this head impact, and that seismic energy flows through the brain and it disrupts the electrical activity. It also, of course, flows through the cranial bones and it disrupts the anatomy there. Um, so, we've been able to screen for, well, we've been screening for concussion, even if it's old, right? A lot of people, one of the powers of I guess one of the powerful things about being human, or I guess a living organism, but we can normalize our state of being, right? And if we have a concussion 2 years ago and we have maybe like, let's say 80% of the symptoms get better, the rest of the 20% can just start to become part of how we see ourselves, or we forget that how we felt before the concussion. And kids are even less insightful, and so they're even more less likely to be like, oh yeah, they're not going to be able to say, I had the start of this problem after I hit my head, right? Um, so, um, so what we've been doing is screening for even subconcussive or small head impacts. It's not always the root cause of everything, of course, but when we start to treat for that, we actually end up fixing enough of the problems that they don't meet criteria for things like depression or anxiety or whatever their presenting complaint was. Um, so I wanted to share with you guys that. Now, what can you do about it? I think screening is a really big one here. I just want you guys to know, these smaller head impacts that happen on the playground, it can be a contributor to the picture that you guys are seeing. Um, and so screen for that. Um, I guess, and then if you want some more help with one of those cases, you can contact us. We can let you know but what to do. But don't take it lightly. These little head impacts add up over time. Think, for example, the CTE literature that's come out. Number one sport that's horrible for you. We all guessed it, football. But what's number two? Soccer. Not as many full-blown concussions in soccer, but repeated head impacts over time um, can get at you, which is probably why I was rather impulsive in college because I played too much competitive soccer before. Um, Thankfully, I got under the magnet and things, I don't know, got better. Good for my wife. Um, Good for my life. So, yeah, so head impacts, um, make it part of your screening process, please. Um, so, I mean, this stuff I think we already knew, right? Basically, TBI can not only make pre-existing psychiatric disorders worse, but they can also um, masquerade as other psychiatric disorders themselves. Um, Saddest cases are, of course, the suicidal ideation and suicide attempts. So, okay. So let's see here. Do I have anything else? I guess that's it. So, um, I'll kind of pause there. Oh yeah, TMS is now FDA approved, by the way, transcranial magnetic stimulation, FDA approved for adolescents 15 to 18. So used to be 18 and up, now it's 15 and up. Um, okay, so got some time here. Yeah, good. Um, any questions? I know that I guess there's some chat here. My son had a tonsillectomy and adenoidectomy yesterday because of his OSA. Oh, no way. Yeah. Um, wow, good for your kid. Yeah. It's so so um
I actually
mhm.
kind of looked into it because he always had the issue, but I think we had Dr. Patel on here once talking about
Oh
it,
yeah.
and it made me think, huh, I wonder if that's his problem. And I took him to the pediatrician and we got referred to the ENT, and sure enough, yeah, he was always just fatigued, tired, and he's usually a pretty cool-headed, mellow kid. And as he was getting older, he'd get like these anger things. So I don't know, we'll see.
How old is he?
He's 11.
Where do you guys live?
We live on the Big Island. So Dr. Mark Sakai just did
What
his
what
yesterday.
part of Big Island?
Hilo,
Rainy part?
rainy.
Dam? Rainy part, dam part. I have this running log in my head. I've always loved geography. And I kind of have an idea of why, and I always ask in my initial assessment where all my patients live. And it's so fascinating, these patterns, especially in Hawaii, because there's so many microclimates. And man, the microclimates make a difference, right? Talk about, chronic variables, low grade over time. Um, yeah, like, and the smallest things can make a difference, like Manoa Valley.
Mhm.
If you live on the east part of that valley, you're basically right up against that foothill. And what are you not going to get as much of? Morning sunlight.
Mhm.
You'll get more afternoon sunlight though. So hopefully that'll dry out some of the wood that gets wet and then, can lead to more mold. And then if you're on the west side, of course, you get more morning sunlight, less afternoon sunlight. And I do think that that makes a difference over time for people.
Yeah.
Um, little things like that. Mold allergies can be really powerful for people, and definitely have an effect on neuropsychiatric function. Yeah, I've seen that a lot too. But yeah, kind of interesting. So okay, so adenoids, tonsils. Um, yeah, and the one thing that potentially to think about for your kiddo is when we've tracked neuropsychiatric symptom response to different airway interventions that leads to improvement in breathing and sleep. We have noticed some trends where um, for actually this was the most profound case that like really caused me to start to you know think a little bit. Uh, oh, well, but we had a patient. I had two patients that come to mind. One had only a tonsillectomy. The kid had more energy and sprouted up. Some of the ADHD symptoms got better, but the anxiety and the emotional sensitivity did not get better. And I was very exquisitely aware of this emotional sensitivity because we also did family therapy. And, the parents couldn't say anything without triggering him. And then, I had another case that had an adenoidectomy and a turbinate reduction. And actually, no, I'm sorry, it was just a turbinate reduction because the tonsils and adenoids didn't seem that big. So turbinate reduction, and she went from severe social anxiety, couldn't go to school at all. And this is a case I've been working with for like 2 years, I think. We've done medications, done therapy, and um, and parents were super on it. The kid was super on it, really bright kid, but had this severe social anxiety that she couldn't go to school. So she gets this turbinate reduction, and then not only does she go to school like literally the next day,
Wow.
but I give her about a month, and when we meet, um, I was like, "So how's it going?" She's like, "Been going to school every day." I was like, "No way. Are you making friends?" She's like, "I have like 20 friends, Dr. Shipley." I'm like, "What?" I'm like, I'm like, skeptical. And and I was like, really? What are their names? She's like super bright, probably like 160 IQ, like type. I was like, what are their names? And she goes up to the board and she just starts writing everybody's name. I was like, no way. Who's your best friend? She's like, well, this person I'm not really best friends yet with, but I'm getting close to her. And I was like, wow, that's really socially aware. And so what that taught us though is that it's different if you help someone nasal breathe better versus oral breathe better, right? There was a difference, and that's when we got onto this whole connection between cranial nerve one and and the anterior brain. So I don't know. I'm not a oncologist, so I don't know if tonsillectomies increase the risk of brain tumors. Um, but so
There's a question right above that. I don't know if you
okay.
know if TMS is available for adults as well.
Through their PCP. So interesting question. Yeah, I wonder if are you wondering if you need a workup? Okay, so like TMS is usually approved by most insurance companies now. If somebody has tried two antidepressants of different classes, SSRI or an SNRI, or Wellbutrin or mirtazapine, Remeron. Those are the four common classes. So you need to try one from two groups, and you need to still meet criteria for um, major depression, severe, without psychotic features. So, and that's usually determined by a PHQ-9 or a HAM-D, so rating scale. So maybe Teresa, your question is, if all of those boxes check off, can your PCP put in the request for a prior authorization for TMS?
I, I,
If that,
I just
yeah.
asked that question because I had a severe concussion in an auto accident and it was a month
Mm.
ago. And so they did the MRI and they said, you're fine, and I don't know, like still not quite sure. But anyway, on another subject,
Oh, is that for
after
yourself or for a patient?
for myself.
Oh gosh, glad you're standing.
So I was just asking, I'm just kind of curious about that.
I see. Yeah, so TMS is still right now only approved for like 99% of the time, 99.9% of the time, approved only for treatment-resistant depression.
Okay, that's fine.
Um, yeah.
But
Hmm.
I wanted to tell you that I've been treating allergic rhinitis for years, and it's just unbelievable. People, 12. I had teenagers who were bedwetting, who completely. I mean, kids just their personalities just completely change around. So
Oh yeah.
so I'm
Oh yeah.
a big
Yeah.
proponent of treating allergic rhinitis.
How long you been doing that?
40 years.
Oh man. Um, well, that's so great to hear, and thank you for your observational skills. That's yeah, it truly is profound. And
And a lot of doctors
yeah.
don't know about it and they're not taught. And I learned this from Frank Yamamoto. He was a great allergist on the cutting edge here in Hawaii, but he passed away. But it really does work.
Yeah.
Amazing. People
Yeah.
come to me, they said, "Oh, you're an allergist." And I go, "No, I'm not."
Yep, yep. I don't know how it's happened, but I have had one or two referrals asking for allergy treatment to me, and so I saw them and I was like, gotta tell you, I'm a psychiatrist, but it's possible that this will help some of your other problems.
Yeah,
Yeah,
for sure.
it's all connected, right? It's all connected. Um, as much as we learn about these things separately, it's not how it works, but yeah, so the allergy piece is big, and I think what we're gonna find is that the nervous system, I like to see the nervous system and the immune system as unique from the other systems in a few ways. But one, and obviously, like I look at this from a behavioral developmental perspective, the nervous system and the immune system are the two systems that help us to adapt to changing circumstances, whether that's pathogens in the environment or changes in the social environment, changes in routine, um, changes in what we eat. Um, you know, any kind of change at that level, the nervous system and the immune system work together, I think, to help us to change and adapt. And when you look at the DSM, our psychiatry Bible of diagnosis, that's always changing. So I guess we're not there yet. But if you look at like what the core issue is for almost all of the problems in there, one of them is that this person has a really hard time with change. This person is stuck. This person is stuck in their addiction. This person is stuck in their negative thinking and their mood, depression. This person is stuck in the future. They're worried, anxious. They're stuck in the moment, and with some certain behavior or thought, OCD. So it's all about this backbone of being stuck. And so that's why I think the immune system ends up coming up a lot for psychiatric patients. There's oftentimes an immune system problem, much higher rates of psoriasis and eczema and allergies. And I think what we're going to find out as we unwind this and go deeper down the rabbit hole of, the most root cause of that leads to all of these, I think the immune system is going to be taking front stage. Um, I really see that as happening, which is also why I think it can be difficult sometimes because by nature of that process of constantly trying to change, the immune system is this moving target. So you get a blood test 1 month and then it shows nothing. And then you get it, 3 months later and it shows everything. It's like, how can that be? And, so, um, but yeah. What else, guys?
We have
Oh,
one other question in the chat. If you could speak on blue UV light and device usage. I do want to have about 5 minutes. I also want to make sure we have time to go through questions if there are
adult.
Yeah, Dr.
quick
Shipley,
questions.
on Behavior Health Echo, you and Dr. Kiefer spoke to the usage and a little bit more about the blue light blockers for the kids, and
Oh,
their
yeah.
device time and how that affects their rhythms and their brain health.
Yeah. So light is, I mean, I guess it comes back to sunlight. The sun is this ever-present energetic signal, and all of our genes have evolved to somehow be related to it or influenced by it. And the the most amount of blue light that we see is generally between noon and 1. It's also when the UV index is higher. Shorter wavelengths penetrate through the smaller atmosphere. And at noon, when the sun comes up, as opposed to the morning or late afternoon, there's more atmosphere to penetrate, not as much of those shorter wavelengths get through. So when the I think it was in like 1996 or 2000, there was a mandate that basically said no more incandescent bulbs. We're going to go energy efficient. Okay, great. Energy efficient means use shorter wavelengths in order to create or use up less energy. So what does that mean? We're going to have more blue light in our artificial lighting. So screens also emit blue light. Artificial lighting can also emit blue light. So some of the modern housing can be really tough on kids with our modern recessed lighting, and it's going to be really cool, white, bright stuff. Looks great for a showroom, not as effective for, our mitochondria. So that signal from the sun at noon, initiates a cascade of hormonal changes. Let's suppress melatonin. Let's keep doing work. And so blue light at night will signal to the body to get into that do mode, which is not where we want to be. We want to be you know, we want to be anabolic, not catabolic. So um, late at night. So the blue light blockers, which is just kind of usually red tinted glasses, um, there's different degrees of blue light blocking you can get, but if they're red, they're blocking most of the blue and most of the green. That can be a really helpful way to begin to reduce, and a cost-effective way. Asking someone to change all their lights, that's a big order. But asking someone to maybe unscrew some of the lights and to wear these glasses, that are about $50, can go a long way to improve sleep quality and behavior quality. So it's not blue UV. UV, that's another discussion. UV light is unfortunately, I think, I mean, and now we're kind of coming around on it, but probably victimized a little bit more than it should be. Like it's not all or nothing, right? We need some UV. Um, and but that's a longer discussion. Um, and that actually I think ties back to the immune system, but um, that's for us to get nerdy about maybe another time.
Yeah. Sorry, I know we're running out of time. Morgan, thanks for
All good.
starting the poll. Um,
Uh,
And I'm sure that's a topic that we could literally have an
I
entire
know. I
session on,
remember
probably.
there was a study being done at a school, right, that put blue light blockers on the screens.
yeah,
Yeah.
yeah, yeah. And there's the blue light blockers on the screens. There's also the study, and this is back in like the 80s. This is before LEDs when there was fluorescent bulbs, which aren't great, where a number of kids were no longer needing to be in their SPED classroom because they changed the narrow spectrum fluorescent bulbs um, to full spectrum, more similar to the sun. ADHD symptoms in particular get a lot better with that. Yeah.
We're just giving folks maybe a few more seconds to add their responses, and then we can quickly go over any questions that were not unanimously correct. I'll call it that. But I do want to be mindful of everyone's time as well. And I know that we're going over just a little bit. It looks like most of them are pretty, most of them are being answered pretty much the same by everyone who's putting in their responses. Morgan, I don't know if you want to give it maybe like a few more seconds, but then we can probably end the poll and maybe just once quickly go over the first question that seemed
Okay,
to have a little bit of fluctuating answers.
I'll go ahead and close it up now. Thank you.
Thank you.
I hope Dr. Shipley, I had to throw those together based off your slides for CME.
Oh yeah. Yeah, no, I think people are, yeah, no, these are great. Thank you.
Could you just go over number one, I think, is the one with a little variant of answers.
Yeah, so I mean, kind of comes back to this table, but if I'm remembering correctly, Prozac was the first SSRI, which means it's the most likely to have the most studies prior to things going generic, and then nobody's incentivized to do studies anymore. So usually when it comes to, these kinds of questions for FDA approval, if Prozac is on the list, you just pick it. There, you just did psychiatry residency. So, but so yeah, that's Prozac. So
Perfect. And it looks like everyone got the other questions right. So great job, everybody. And I know we are over time now, so I will let everyone go. Thank you so much again, Dr. Shipley. That was a wonderful, very engaging presentation. And I think we all learned a lot. It was especially interesting, really just having all of those just highlighting really how much it all really just kind of ties together and really how much further we need to be looking, especially with things like sleeps and allergy controls. It made me think a lot about my own sleep.
yeah, yeah.
It's probably not the best thing to be thinking about too much. But I really appreciate you. This is our last session for the year.
Oh yeah. Wow.
Thank you, everyone. I hope everyone has a wonderful holiday season and a great start into the new year.